Dr. Tuckson, thank you so much for coming up to Brown and being willing to share your insights with us. I've long been an admirer of your work. You've done so many things. But I'd like to spend some of time today hearing a bit about your work during COVID and the coalitions you built, and sort of what called you to that work and what were your biggest lessons from it.
Well, thank you for the opportunity. It's great to be here in Brown, I'll tell you. I was fortunate enough to be the Commissioner of Public Health in Washington, D.C. during the height of the AIDS epidemic between 85 and 90. And while doing that work, I was indelibly impressed by how important it was to have a community-based infrastructure in support of what the public health department was doing. That you really had to have a top-down and a bottom-up, and they had to meet. Unfortunately, it wasn't that great, and I wished I had more support. But still, I was able to engage a series of influencers from across the community in D.C. And so when Easter Sunday, 2020, I will never forget that looking at the data, and you could sort of see the train wreck that was coming called COVID, and I knew how difficult it's going to be for the Black community in particular. Everyone had, as a professional obligation, to decide what their response is going to be. I wasn't clinically practicing anymore, but I signed up in case everybody else fell over. The third string would come in and I would help. This was not appreciated by the family, my grandchildren. It was, but I began to really start in their impetus to think about what I could do, and I realized that I knew something about bringing together communities and in support of the major public health challenges. And so I started dialing that to the representatives, people that I knew from the faith and community-based health organizations, entertainers, musicians, poets, people who were interacted with the incarcerated community, those who were returning citizens, faith leaders, and so across the board in a very broad way. And I was very excited to find that everyone responded to our call. They said, let's come together and let's see what we can do. And so we were able to create something called the Black Coalition Against COVID. And from a standing start, no resources, no money, no nothing, but just with goodwill and a sense that we have to respond with. That began a steamroller effect that started to spread very rapidly, but quickly we began to also see that a vaccine was going to be critical. And that meant clinical trials, and that meant overcoming the legacy of the U.S. Public Health Services experiments in Tuskegee. It meant overcoming the impromptus of the Henrietta Lacks experience and just generations of distrust. As a result, we then called and brought together the 4 Black medical schools, Howard, Meharry, Morehouse, and Charles Drew, their leadership, their presidents, along with the National Medical Association, the National Black Nurses Association, the Urban League, as well as the largest digital publisher of health information for the Black community, blackdoctor.org. All of that became the national arm of the Black Coalition Against COVID. And with them, and in partnership with many leaders from the federal government and other scientists of renown, we were able to push really forward a whole series of town halls that some as many as reaching an 800,000 reach one night. That was really special for us. But we did over 30 of those during the pandemic, along with other activities. And so for us, that became the basis of what we did and how we had to respond. And I think we learned an incredibly important lesson. And that lesson really is that it is possible to bring together the Black community in very powerful ways, combined with expertise and a sense of mission and passion, and have some success.
That's really quite an inspiring story. And I think there are broader lessons for how we think about communication and just engagement with all populations. And what have you seen in terms of the COVID data? I mean, I spent a lot of time tracking the COVID case, hospitalization, and death rates. And, it was very clear very early that there were deep disparities in who was contracting COVID, who was being sent to the hospital, and who was dying from it. And, I think if we take away any one story from COVID, which is impossible, it's that these disparities, I think, really told a tale of how we need to respond better in the future. But there are also, I think, some really points of light in some of the data in terms of the the product of this kind of outreach and what we've seen in terms of, changing trends in vaccine uptake, et cetera. Do you have any reflection?
Well, you make two important points. And on the first one, in terms of what we learned about the disparities and its relationship to etiology, to the spreading of the disease and the confounders of our responses, I really remember so vividly that when the vaccine first came out and it was in very short supply, there were mechanisms set up to provide access that were computer-based, that required a certain sophistication of interacting with that kind of engagement, and we weren't as good at it as some of the other folks in our country. And in fact, it was quite a shock in so many places to see on Martin Luther King boulevards all around the country white women with fur coats being in line to get the vaccines, never having come into our community before. And so we learned a lot about the social impediments for mounting an emergent campaign to save lives. However, the much more important reflection that I have was the success. And we now have found that in first primary series COVID vaccinations, we closed that disparities gap despite all the baggage coming from so far back in the pack, but we tied white America. And that's an amazing feat that shows us what's possible. But what's even more important, and this is the real key that people need to focus in on, is that by the second year, black life expectancy, the loss of life, was less for black folks than for white America. That we, as a result of our efforts to get our community vaccinated and all the other protective measures, mask wearing and so forth, that we were able to actually save more black lives than white America could, with all of the advantages that so many of them had. And so this sort of tells us that when we organize ourselves to fight for our lives with the good support of others, thank God for the support that we receive from others, that when we fight for our lives, we can succeed. And that gives us optimism and hope that we can do this all the way now for the pre-existing challenges that have that have plagued us for so long.
There's so few points of light in this pandemic, but I think the lesson that you're really hitting on should be a guiding post for us for the future, which is it speaks to the promise of what we can do with commitment, with community engagement, with targeting our response to make sure we address what we are seeing very clearly in the data, and to not just collect these data to satisfy our curiosity, but to inform our action of what to do to correct that.
I think that translation of expertise into tangible action is really what a place like Brown is all about. This is what the public health school is good at, and I think we have to continue to remind our students and our young professionals that we must really know our craft well. But knowing our craft well is much more complex than ever before. We have to know our fundamentals, but then we have to know how to apply those fundamentals in the real world so that it changes the course of events. That is an extraordinary augmentation of our expertise, but one that I think that we'll be much better prepared for in the future.
And the community will tell us about our craft and how best to apply it. And I think that's what I take away from your work, is that there was really a responsiveness, a listening approach in the sense that you held these sessions and you heard from people about what their experiences were and allowed that to help shape the response, as opposed to kind of a top-down directed, perhaps not aligned with the wills or values of the community approach that sometimes we can fall into the trap of in public health, particularly when there's an emergency.
Yes, there is certainly room for encouragement, but within that is an enormous amount of remaining frustration, because there's so many people that we didn't reach and couldn't reach, and they're going to be harder to reach with every passing day. And what we've experienced is not only in the black community, this is across America. I really feel sad, and I have enormous empathy and compassion for the white community, especially in the red states and the red counties, who were the ones that died unnecessarily. And it is still amazing to me that even in that community, there has been so little attention on the part of their own political leaders that people died that didn't need to die. And that's frustrating. But I also know it for the Black community. There's still too many African Americans who have bought into the conspiracy theories, who are being still directly targeted by the forces of evil. And then also just from a cultural point of view that make it much more difficult to lock in with these kinds of scientific-based, evidence-based principles. So there's a lot more work to do. And we're excited by the demonstration of success for parts of our community, but we still have a long way to go to reach everybody.
Right. So on that, sort of the next steps, you are continuing the work that you started, the coalition building that you didn't start during COVID, but applied your skills in coalition building to the COVID crisis. Now you're continuing to do work, and you're taking on the very extraordinarily important, but incredibly, I would think, challenging work of building trust and tackling the trust crisis that we seem to be even continuing to experience now, 4+ years after the pandemic. Can you share a bit about that work? And
right before the pandemic, I noticed in the media a report from the Business Roundtable where people like Jamie Dimon and Jeff Bezos and others of their ilk announced that maybe return on shareholder value was not the most important thing that the modern CEO should be held accountable for, but their social responsibility to the communities in which they live and work. Well, this is an astounding statement. And I was embarrassed as a health professional that we in the health industry had not said that ourselves first. And so as I started to look up after the pandemic started to wane and we could see over the barricades enough to see the rest of the world, we were certainly influenced heavily by the sense of distrust and mistrust and misinformation that the Black community was plagued with, but also for the white community. In fact, maybe even more so than the Black community at times. And so the thought was, could we, for the first time in history, bring together the entire health ecosystem? Can we get all of the health leaders to decide that this issue of mistrust, distrust, and misinformation is such an existential threat to every health concerned organization and every oath that every health professional has ever taken, that this is core to what and who we are? Could you in fact assemble the industry to fight this concern over time? To our surprise and joy, 90 organizations have currently signed up to be members of the Coalition for Trust in Health and Science. And that's everything from the American Association for the Advancement of Science and Academy Health, so the research world, bio, pharma, AMA, Council of Medical Specialty Societies, and many others, the American Hospital Association and the Federation of American Hospitals and others, AHIP for the insurers, APHA and NACHO for the public health, all the way through pharmacy organizations, American Telemedicine Association, home care, all the way through to the National Health Patient Council for the consumers and the National Consumers League, and lots of stops in between on that train. It has been a fascinating thing to experience this willingness for the profession, for the industry to come together. We have a lot to learn first, and so we've really focused ourselves on teaching ourselves. What does the evidence say about what works and what doesn't work, and the etiology of this misinformation and mistrust? How do we come to understand it from a scientific evidence point of view? How do we and so we've been bringing together the best scholars in this field from within health and, excitingly, outside of health, because this is a social, and this is not segregated to just health concerns. This is in every sector is facing the same kind of problem. So who are the best thinkers? We've been able to attract them, learning from them, and then disseminating that into our members every other week, learning lunches with the best thinkers, one of whom has been one of the most important people that has taught us what we need to know is Claire Wardell from this institution, who is just phenomenal. And then we've been able to start to think about our capacity. 90 organizations, each of whom have their own communication specialists. So now a rapid response, tracking misinformation, and then being able to respond quickly is the capability that we're moving towards. We've got another group of panels who are the best communications experts that we can find. So we're really excited by being able to move this forward. We have a lot to do. It's gaining momentum. Well, we just got our first grant, thank goodness, so we've hired an executive director. I now know that I learned quickly what happens when you have a dog chasing a car down the street. What happens if he catches it? You get dragged down the road 90 miles an hour by your teeth until your legs brought out. But now we've got an organization in place, and so we're pretty excited.
That's really, really exciting. I'm wondering if I could run a hypothesis by you based on an observation during COVID. Now, you have worked on both the sort of public health side and also the healthcare delivery side. You're also a clinician. You have been at the bedside. So you've seen it from sort of a range of lenses that you've worn. Like you have spoken to many people throughout the course of the pandemic. And one observation I made somewhat early on is when I'd talk to people and they would have lots of questions and they were coming for answers to their questions. But it was very common that you would hear from people, I just don't know who to trust. And for a while, I started doing the thing that we are often trained in public health to do, which is to say, well, do you think you could talk to your healthcare professional? And I very almost exclusively in those conversations would hear back from the people that came to me, I don't have one. To the point where I just stopped making that suggestion because I just assumed that that was the case among the people that I spoke to. So I'm curious in your work if you're seeing how much of it is an infrastructure issue, how much is it a services issue, a sort of pre-crisis. We're not in the lives of people every day. Then we show up in their lives in a crisis, perhaps in ways that may seem at best confusing, but at worst at odds with what they wish for themselves. How much of that is what we are seeing in this crisis? I understand that it's complex, but I'm curious how much of it is about our health system and our abilities to access it, and how much value we perceive it to provide us.
I wish that was the problem in a way, because you could then get at it. This issue is, I think, much more insidious. And even when you have a health professional, I mean, just the stories are extensive on the number of health professionals whose patients continue to use ivermectin, even you say not to, who still do not believe or trust. And so it isn't so much that. I think what we're really facing is a sense of that we as health professionals and we as a health industry have gotten, there's too much distance between us and the people we're serving. We're not a part of their lives, and we are not as trusted, even though the data says I trust my doctor, but still people don't always act on that. I think what we're seeing is this first of all, a whole rebellion against the elites themselves, and we are elites. We're perceived as elites. And so there's the fights that are going on the college campuses now, the attacks on the Ivy League schools. There's this sense that that these elites are disconnected from the fabric of mainstream life. And therefore, all of that is suspect. How could a man with the credentials of a Tony Fauci, impeccable expertise, an impeccable, nice man, as decent a human being as you could ever find, how could he not be trusted? And that means that the problem is that's a second level of the problem, and that is the deliberate manipulation of perception of people. That Tony Fauci was not as trusted as he had been in previous iterations of his career, because there was a deliberate campaign to undermine him by people. And that is that deliberate undermining for political purposes that is the second biggest challenge, I think, that we're confronting. And we're going to have to really start to understand the magnitude of that manipulation going forward. People have a need now to believe in their tribe much more than they need to believe in anything called truth or evidence or science. It's my tribe, and those tribes are becoming smaller and smaller, so that it becomes even more difficult to find the grammar to cut through some of that nonsense. So I think this is going to be a problem for a good while, and there's no easy solution. We just have to continue, I think, to what we do. We're going to have to continue to reach across the divides. We're going to have to continue to embed ourselves inside of the life of community. But also, one of the things that I like about what Brown is doing, and I'm very excited about it, is also focusing on bringing more people from communities that have not been a part of the conversation into the academy, into this, so that we are not having to convert people, but that the people who are from the culture themselves are now able to be a part, and then they can continue that conversation with their friends, neighbors, and peers.
About some of this tribalism and this polarization, there have been some recent study that I saw that talked about from a behavioral social science perspective that perhaps more important than differences of ideas is differences in how perceived likability of the other group. So that some of the polarization is because I don't like this other group versus I don't agree with them. That's a particularly hard problem to solve, but I think it really points to the need to reach across and to engage with others so that we can learn to like each other, that we could be in each other's lives and spend time with each other and see that, we may have some differences, but we also have some commonalities as well.
Well, certainly. I mean, but I think what you put your finger on is the sense of if you're not one of us, then you're not reliable. And that the notion of these decisions that are being made today are much more on emotionality than they have to do with rationality. And that somehow or another, that sense of tribal affiliation is just more important to me, even sometimes than whether I live or die. It matters more to my peace of mind in a complicated world, a world that is so seemingly out of control, a world that it seems that I cannot exert my own influence on anymore. I need to be a part of this protective shell. And whatever that protective shell says, this is where I'm going to be. And that means more to me today than even when I wind up in the hospital dying and still denying that this disease can kill me or that I even have it and still refusing to take some of the treatment. It is that deep. And I think that what we have to start to understand is why. And as you say, how do we then stretch into knowing folk and being able to talk with them? But the other problem here too, the two other cotangent problems to this very complicated puzzle is, number one, the lack of science literacy. Our world is complicated. The world of medicine and health, mRNA vaccines are a complicated thing. And it is not a part of the vocabulary of the average American. It hasn't been taught in science. We don't have the background that allows us to fully appreciate the rapid technological advancement in our biological knowledge. And so that inability to have the background to fully understand is important. But then secondly, it is the narrowness of the information sources. We either get our information from Fox or MSNBC, maybe in the middle, CNN. But what you get on Fox is a very narrow slice, and it's packaged in a way that if that's all you have, you will easily believe the things that are the misinformation and the disinformation that is being promulgated. Similarly, online, I think that we in public health have never confronted a problem like social media, especially one where you naively ask a question and then find yourself down a rabbit hole that you never intended. And you start at one place and you end up at a very strange other place, and then you're caught and you're captured by that. These are unprecedented challenges for the modern health professional, and we're going to have to ramp up in a whole new way. And I do hope that, again, not getting away from our traditional fundamental blocking and tackling expertise, but we are quickly now become aware that our fundamental expertise left to itself is inadequate, that it has to be applied in service to the society in ways that we are not well prepared or have not been taught how to handle.
It's so true. And to your point about emotions being part of it, and yet in public health, we're so trained to communicate the facts, so the facts only. But some of these decisions are not, as you said, made based on facts. They are made based on emotions.
But other one thing that's very important here as well, and that is this: the complexity of these decisions require nuanced judgments about risk-benefit relationships. Do we have the children go back to school in the pandemic, knowing what that means in terms of keeping them out, what that means in terms of their educational development and what's for it? So what is the appropriate level of risk that we're willing to take for the children's sake? Add to the even more complexity, the teachers. And many of the teachers who have their own risk factors and who are caring for elderly people in their own homes. So in all of these discussions, we're going to have to understand that we we're not the only ones who should call the shots. This is going to require a process that allows a community of people to come together and be able to work these things out. But the sense that we sort of stand on high, saying we have the facts, and we know that therefore the interpretation of those facts ought to be clear. The consequences of those facts ought to be very clear. May not be an assumption that we want to hold on to sometimes. We will, but that then presupposes that we have developed a priori some sense of a shared community vision for health and where health fits in the overall society vis-a-vis the economy, employment. All of those things are now, we're in all of that now. And if we don't do the work on the front end to be clear about what are the assumptions for a shared vision for health and where that fits into the hierarchy of societal concerns and how it integrates with those other factors, we will not be successful the next time around.
So true, so true. On that note, I'm talking about the process that we need. I'm really excited about your work with the coalition, and I'm very heartened to hear you've gotten granted an executive director. So it sounds like the future is bright. I do worry, though, generally, and I'm curious what your thoughts are on whether we are making the investments we need to kind of do the work after the very tough experiences we went through for the pandemic. In my view, the need for these coalitions is very clear and compelling. The resources may not be where we need them to be, but I'm curious what your thoughts are in terms of the work going forward and how do we sustain the work so that it's not just another one of these examples where we go through an emergency, we collapse into a heap afterwards, say that was terrible, and then forget all about it.
I'm an optimistic person, but I'm a realistic person. And when I confront a challenge, I don't want to be afraid of defining the dimensions of that challenge, the depth of that challenge. So let me be clear. We're not going to have the money to support this work. It's going to be very difficult. And the reason is because of the politics. People are scared to death. To be hauled in front of a Congressman Jim Jacobs' committee, which feels very much McCarthy-esque, causes people to back off. All around the country, we are seeing this retrenchment on whether it's DEI or whether it is on misinformation. People who do the work around misinformation are going to face challenges. It would seem it's too hard to even believe that could be the case. But if you say that you're trying to talk about misinformation and disinformation, you're going to, as a company, a corporation, as an academic environment, institution, you're going to be putting yourselves at risk. And we are seeing money dry up as a result. So I thank God for the people that are willing to support it, but I think that the resources for this are going to be tough. And that's why I'm so proud of the colleagues, the 90 plus organizations that are part of the coalition. They are saying, we will figure this out, we'll do the best we can. And the amount of voluntarism, the amount of just the giving of intellectual talent and sharing of it in varieties of ways. Our team that created it, Bill Novelli and Mary Naylor and Julie Gerberding and Sudha Parikh, Elaine Arkin, all these people that have come together, those folks worked for a year every week and through the week with all that they had to do, but running it, we ran it ourselves without permission and without resources. We just did it. And that makes me very proud, but we need much more support.
So maybe my last question for you, and thinking about the support and thinking about sort of what's coming next, the next generation. And I'd love to hear your thoughts or your best piece of advice for public health students now, people thinking of pursuing public health careers, based on your recent or whatever experiences. Yeah. What's the piece of advice you would give young people? And then maybe selfishly, what can we as schools of public health do better to meet the challenges of the future?
Well, 3 quick things for the students. Number 1, be very in touch with the passion, the the ethos that caused you to want to be in this work. Don't take that for granted. You have to nurture that tender, delicate flame and attend to it every day of your life, because that flame can go out. And that is the most important thing. Why did you decide to do this work? And what is that ethic, that incredible spiritual thing that within you that causes you to want to do this? Number two, just really have to be tight on the expertise. You got to be competent. Know your craft and know it well. And then number three, in this regard, is stay in touch with your community. Stay in touch with wherever you come from, but do not let yourself get off base. Don't come to a Brown in this elite academy and forget that you're from little town in South Dakota. You need to be in South Dakota as often as possible and being of the people there and bringing that to the academy and vice versa, back and forth. So don't get off base, because the pitcher will throw you out. And in terms as far as the university itself, the School of Public Health, I really think that we have got to move to this notion of, after the due diligence on the pedagogy, is how that pedagogy can actually then be applied to change the world with all of the conundrums that are part of it. And stop calling that soft science, stop calling it politics, stop calling it whatever it is, that somehow or another we look down upon the person who actually, we don't look as up to the person who is knowledgeable about how expertise gets translated into service to and discourse with society. Service to and discourse with society is an ethic that we are, the translation of expertise into that. So it presumes the academy, we're teaching the expertise. Now we have to teach how to translate that into service to and discourse, because absent that second piece, hundreds of thousands of people die.